Hi, Gibson, Sanjit Jolly, and we're talking about colchicine in the setting of ST segment MI and its benefits or lack thereof. Sanjit, talk to us a little bit about the design of the OASIS 9 Clear Synergy study.
Absolutely. I think there's been a lot of interest in the inflammatory hypothesis, probably for the last 20 years. And for the first time, probably nearly a decade ago, the canakinumab data came out positive in the CANTOS trial. So an IL-1 inhibitor, very modest reduction in events, about 15% reduction, and that really led that maybe there was something to this. And then there have been two colchicine trials in the last kind of 5, 6 years, the Colcut trial and the Lidoco 2 trials, which were both positive for colchicine. And we had been running this trial for probably about the last 5 years. So we were running concurrently with their trials, but was the largest and took longer to enroll. And this was really, we hoped, was the arbiter. Does it colchicine work? Does it not? Um, and because certainly the guidelines are switching, the FDA's approved it, but clinical use remains very, very low with colchicine. I don't know if you prescribe colchicine in your practice. Um, I only use it in a very small percentage of patients.
Yeah, I think, if someone's having breakthrough, events and they're on aggressive lipid lowering, things like that, that might be a place where I would use it, but otherwise, no.
Yeah. So we randomized 7,062 patients across 104 centers in 14 countries, and it was a 2 by 2 factorial design. And today we're only going to be talking about the colchicine versus placebo. But another interesting hypothesis is that we tested was spironolactone versus placebo routinely in patients. Um, this included both STEMI and non-STEMI, but it started off as a STEMI trial. Non-STEMI was added afterwards, and about 95% of patients were STEMI.
And how many did you study, and what was the primary endpoint?
So 7,062 patients. The primary outcome was a composite of cardiovascular death, MI, stroke, and ischemia-driven revasc. So fairly standard across the other colchicine trials.
Yeah, that's a big study. And what did you see?
So first off, we looked at the biomarker CRP. Now, CRP was not measured in everybody. There was a subset of patients, probably about 2,000 patients that had CRP measured. And CRP was very high at the beginning in the midst of an acute MI and dropped, but it dropped more significantly in the colchicine group versus the non-colchicine group. So there seemed to be a biologic effect here. And so we hoped we'd see an effect on clinical outcomes. The event rates were fairly high, about 9% in both groups, but it was not difference. The hazard ratio was 0.99, p-value is not significant. And when we looked at the components, CV death, MI, stroke, or ischemia-driven revasc, there was absolutely no effect. Um, the only outcome which was different was actually non-CV death was slightly lower with colchicine versus not, but small number of events, we thought it was a chance finding. And one of the important stories before this was that previous meta-analysis suggested the opposite, that colchicine reduced cardiovascular events but increased non-CV death, and I don't think that's the case based on our findings.
So, how do you explain the discrepancy with previous results? Have you done a meta-analysis to put all of this together to see what happens when you add this to the body of literature? What are your thoughts?
Yeah, so we are currently doing that meta-analysis right now, along with the colchicine trialists, um, and I think I think one of the most important things is this is the largest trial with more than 600 outcome events. The Colcut trial, which is the most similar trial, had 200 outcome events, so we had 3 times the number of outcome events. I think the second issue is, did COVID-19 affect this? Because we ran through COVID, we did analysis looking at various time periods. There was no significant difference across the different time periods. Third, our discontinuation rate was slightly higher, but likely related to COVID-19, about 26% overall, comparing to about 18% for Colcott. But our trial was longer, 3 years, and the on-treatment analysis again showed no effect. So, you know, I think this really questions the previous findings of colchicine. And I think the other thing is there have been two recent stroke trials looking at colchicine in patients with vascular disease. One was 3,000. One was 8,000 patients, the Chance 3 trial, which was wholly neutral as well. So this may be regression to the mean, that as we get more data, we find out that maybe a therapy that looked good, perhaps is not as effective as we thought. And finally, we can't exclude, fairly modest, like 15% reductions in events. That may still be possible, would require much larger trials.
And, did you study the same populations in the same countries? Sometimes there are country-specific variations in how patients are managed, and
Mhm.
if they're less aggressively managed in a country, maybe this drug will make a difference. I mean, is it possible that there's a difference in the populations who were enrolled?
Um, I suspect not. I mean, the Lidoco 2 trial was really a Dutch and Australian trial, and the Netherlands was a big recruiter. Same study drug, same PI as Lidoco 2 ran our group in the Netherlands. We had Australia as well involved in our trial. This was primarily, North American, European, so very similar to the countries that were involved in the other trials. Um, I think the caution is um, the Lidoco 2 trial, which is really the trial that had the greatest effect size, was actually two trials merged into one, so that there were actually two separate trial databases, and they were merged at the end with the same protocol. And the smaller population in Australia had a 70% reduction in events. The Dutch population had no effect. So if you look at it, this is one of the challenges when you put data together. If you've got a smaller trial with a huge effect, it often influences the effect overall that you see when you put them together.
Yeah. This is why we do research.
Yeah,
You ask an
exactly.
honest question, get an honest answer. I look forward
Yeah.
to seeing that pooled analysis. Congratulations. I know how hard these studies are to do, Sanjit. Thanks for joining us, and thanks to all of you for joining us here today.
Okay. Thank you, Mike.
Thank you.